Good afternoon and welcome to one of the most interesting sessions at EuroPCR, Left Main and Complex Bifurcation Center. These are my conflicts of interest. We designed this session because of your requests. We received several requests all over Europe to repeat session that was fantastic presentation from Masida last year with stepwise provisional stenting in complex left main bifurcation anatomy guided by up-to-date intracoronary imaging. So the goal for today's session is to understand the best treatment options for patients presented with left main and complex bifurcation or trifurcation disease, to learn how to optimize both the strategy and the technique using intracoronary imaging and physiology, and to understand mechanical properties of newer generation Ultimaster Nagomi drug-eluting coronary stent system and share the latest clinical data. My name is Goran Stankovic and I will co-chair this session with my colleague and friend Tom. We have Francesco as a procedural analyst and we have fantastic panel of discussants, Maciel, Yoshinobu and Daniel. Procedure will be done from Massi by Akim and Thierry, and we have Cath Lab medical coordinator Mariama and on-stage coordinator Denise. Please use mobile application to ask absolutely anything related to complex left main bifurcation treatment. We will be so happy to discuss with you and share our knowledge and practice. Please use also standing microphones here in the theater blue during the discussion part of the session. So I would like to hand over now to Tom to present the patient.
Thanks, Goran. And it's my great pleasure to present this patient on behalf of Thierry and Hakim. This is a 73-year-old gentleman who's been referred through the outpatient clinic for coronary angiography due to a presentation with exertional breathlessness and a recent exacerbation, despite the fact that he is on optimal medical therapy and has undergone a CT scan prior to arrival in the cath lab. Background risk factors are of hypertension, hyperlipidemia, really otherwise nothing remarkable to report. And from a medical therapy perspective, just on perindopril, aspirin, atorvastatin, and bisoprolol appropriate for his presentation. A low but normal hemoglobin, a normal troponin, and the renal function, a GFR of 75. This is the ECG, which is unremarkable. And an echo has been undertaken demonstrating preserved LV function with no significant abnormality. It's important and interesting to review the CT scan prior to coming to the cath lab, and obviously what is identified is a high burden of calcium in the distal left main extending into the LAD, and we see actually a almost trifurcation anatomy, so this high diagonal but within 3 millimeters of the ostium, so would be kind of defined as a trifurcation anatomy with this calcification, very nicely demonstrated on the three-dimensional reconstruction. If we look at the multiplanar imaging of the LAD, then obviously we see again this calcification in the proximal segment, but importantly a more critical stenosis in the proximal to mid-LAD, which is absent of calcium. But we see this arc in the left main of 90 to 120 degrees. The other aspect in terms of pre-planning is to see that the lumen is also of a good caliber, 5.5 millimeters in the left main, 3.5 in the LAD. This is obviously the more usual way for us to assess the coronaries, and here is a diagnostic angiogram which confirms mild to moderate proximal right coronary disease. And then moving to the left, then we see this moderate mid to distal left main stem disease extending into both the LAD and that intermediate vessel, and then the more striking appearance of a severe lesion at the level of a large septal branch in the proximal to mid LAD, seen here better in the cranial projection. And here now we see some caudal projections and really delineating that trifurcation-like anatomy between the LAD, intermediate, and circumflex. Just move through these. So we have a 73-year-old male with a significant bifurcation lesion, 110 in the left main, but also this proximal to mid-LAD lesion. The syntax 1 score is calculated at 22 with an STS score for bypass demonstrating an operative mortality of 1.35, morbidity or mortality of almost 5%. I think interestingly, the syntax 2 score demonstrates actually a superiority of result anticipated by PCI with a score of 28 against 36.3, which gives a mortality at 4 years of 5.7 versus 11.3%. So as a result of that, the heart team decision in Massey was for an image-guided, here an OCT-guided distal left main PCI in addition to treatment of that severe LAD disease. And so the key clinical data with this image that we've already reviewed, but as a still frame, is one of a patient presenting with CCS, but with very limited comorbidity and good LV function, and this plan to proceed to image-guided intervention. Goran.
Thank you so much, Tom. It's excellent presentation. And I would like to use this opportunity to have Yoshi Onuma here. We discussed, Yoshi, a lot about non-invasive evaluation, and I'll try to go back to CT finding and ask you to share your perspective. Maybe Tom can help me. Your perspective, if this is your patient, how would you use the information? And what are the most important key informations that we use to plan strategy upfront before we enter the cath lab and perform angio?
Yeah, thank you, Goran. I think that this case really illustrated how much information we could get from this non-invasive imaging. So recent survey of the all-comer PCI trial showed that the approximately 30% of the case we have in cath lab already have a CT before coming to the cath lab. And sometimes we don't look at the image so carefully, but here it's really a good demonstration of the pre-procedure assessment of non-invasive imaging by the CT. So first of all, there is the lesion-based calcium score, which is for the left main 190, and this is not really too much calcification, because if the lesion-based calcium score is more than 450, for example, then you probably need to end up with using the rotablator during the catheterization. However, in this case, that the total calcium score is 260, I think, and the left main is 170. There is a calcification, and if you look at the cross-section of the left main lesion, the calcium is there, but not really too extensive. Let's say in cross-sectional way, the angle of the calcification is limited to the 120 or even 90 degrees. So I think that you don't need to have the adjunctive therapy such as rotablator. Maybe the non-compliant balloon is enough to expand this calcified lesion. And the other component is that you can also anticipate the sizing of the stent. So proximally, it is a very large vessel, 5.3 on average. And distally, if you go really the distal to this mid-segment stenosis, the diameter is approximately 3. So you can really expect that too much tapering after the left main. And there is some, I think, area of a landing zone. Probably we will discuss later, but in the proximal part, it looks like not too much disease. So maybe you could stent stent, or because there's some looks like a disease-free zone in CT, but probably we need to confirm that OCT. So
great. I see that Francesco is already working on the smart board. So, Francesco, please take a lead.
So I tried to follow, because I feel that in the future we will use more and more CT scan to evaluate the patients before they enter in the cath lab. And one of the challenges we have probably as interventional cardiologists is the fact that we will start thinking about PCI procedural planning as we do for TAVI, looking at CT scan. So honestly, if you look at this amount of calcium, I mean, you can be scared, but the re-evaluation by an expert interventionalist who knows how to interpret the reaction and the thresholds that can influence the outcome of our procedures, it has been very well simplified. So here we know that there is calcium. For sure we will have predilation to be performed, but at the end is the type of calcium we think we will be able to displace with these stents. Because look here, I think that it will be possible to implant a stent and expanding it, pushing a little bit the calcium here and opening up the lumen very easily in that area. So that's the translation of the concept of not having a 36 degrees amount of calcium.
Yeah, I will use again the expertise of Yoshi. You were one of the who designed its syntax 2 score and helped us stratify. Can you also comment on the evaluation importance nowadays of performing not only angiographic but also syntax 2 when we discuss the strategy, whether we need to go for PCI or surgery?
Yeah, thank you. So syntax score 2 is designed to combine the anatomical syntax score and the clinical factors such as the H creatinine clearance, ejection fraction, and COPD, and peripheral artery disease, which was deemed to have an impact on the surgical outcome. So by using a syntax 2 score, you can predict the mortality after PCI or mortality after CABG. And in this case, particularly the syntax score, anatomical syntax score is not too high, it's a 22. It's a kind of the low syntax score category if you use the threshold or tau of the original syntax trial. And if you look at the syntax 2, mortality after PCI is significantly lower than the predicted mortality of the CABG. So from the mortality point of view and the individual risk assessment point of view, I think this patient is better to be treated with a PCI.
Because we see and expect benefit of PCI. So no dilemma. Non-invasive imaging, extremely helpful to understand the anatomy, plaque burden, plaque distribution, to plan the strategy. But then we go to cath lab and perform angio. And if we can have angio images, it's already there. And I'll start with Maciej. Maciej, if this is your patient, it's complex anatomy, left main, proximal LAD, some disease of the ramus, or high diagonal origin, some disease on the circ as well. What would be your strategy as one of the most experienced centers in Europe?
Yeah, definitely this looks really complex, but if we come closer to the image and what we know from the CT, I think that still we can use this minimal option, so start with a one stent strategy. With, of course, some additional data we need, I mean the intravascular imaging. So if we have a device that can accommodate to this complex anatomy, because if you have 3 branches, then the drop in the size, in the diameter will be high, so you need to have a device that can accommodate like 5.0 or even more for the left main and 3.5 for the LAD. I would start with a provisional strategy, and then, of course, during the procedure, if needed, still a lot of options to stent the side branches.
3 wires, pre-dilatation.
Of course, 3 wires, pre-dilatation. The first imaging, if possible, sometimes maybe difficult.
Yeah, it will be very nice to have upfront imaging before you pre-dilate.
Then pre-dilatation, mostly towards the LAD. Of course, we need first, I would fix the LAD, the mid-portion LAD lesion. Then I would stent the LAD towards left main, optimize result with POT, opening struts, and perhaps kissing, tracing. Yeah, it depends. And then I would look.
The beauty of provisional is that we don't need to decide now.
Yeah.
We can start with stenting towards the LAD, optimize the result, then evaluate, then do kissing, then evaluate. If we need second stent, Daniel, what would be your strategy? You agree with Maciej, provisional, taking care first of the prox LAD, then single stent from the left main into the LAD, 3 wires, and then optimization.
Well, I agree. I mostly agree. I think this is a straightforward case to the LAD because the LAD is driving a lesion, the mid-LAD, but also the left main. So the angle to get back to the two branches is not too bad. And when we look to the criteria of bifurcation treatment, the disease in these two branches is not too much. So I think we should opt for a provisional strategy. We will see during the procedure how it evolves, because PCI is an evolving intervention, so you never can tell us what will happen. But I think I'm very I think it's very probable that we can go for provisional in this. You can discuss about one stent or two stents. I would prefer, as Manuel said, to go and fix the LAD and then go for a stent to the left main. And I go for kissing with two balloons, but we have some data on triple kiss. You have to go to the distal strut and then open up to the circ. So that would be my my strategy.
Thanks. You know, I know nobody better than Francesco to help us understand what we see, what does provisional strategy mean, and what are your suggestions for our team in the cath lab?
So I want to reflect with you about the differences into the trifurcation anatomy as assessed in these two incidents. Here it seems clearly that is a first diagonal. Here it seems clearly, a trifurcation. So at the end we know by CT scan that it is a diagonal that is close, very close to the left main. This means that this is definitely trifurcation anatomy. This means 3 wires. And since the two branches are very huge in terms of jeopardized myocardium, we should aim at having a good result also into the side branches. So some interventions will be possible, but we should be open eventually to fix in bailout in the case that we are unsatisfied or there is dissection, to implant a second stent. But this is trifurcation anatomy. We know that if we got inside more metal inside, we will have poor outcome. This is what we know according to the few studies we have on left main trifurcation. So provisional makes sense because we will try to fix it with one stent, and eventually we will use as much as metal is really needed. Final, for provisional, which is the risk of having jeopardized the flow in these branches? I think that integrating the CT scan with the image by angiography, we can imagine that the vast majority of the plaque will be here, on the opposite to the bifurcation area, with the calcium that is a little bit deep here. So I think that we will have low risk of complete jeopardize of the flow into the side branches, but a wire will help us in solving in the cases needed. This is my takeoff.
This is great. I like very much that you demonstrate that plaque bifurcation is the lateral wall opposite to carina. Carina is usually free of disease, so the risk of compromising both other branches, diagonal and circ, is relatively low, so risk of plaque redistribution. But what do you think about this discrepancy in diameter?
Exactly. I want to come back. So since now we have a program here for the left main, we should not neglect the fact that the tightest lesion is in that area. And we have two alternatives: to try to fix everything with a single stent coming up to here. We have now devices like that. Probably, we will implant Ultimaster that has the longest available, as far as I know, drug-eluting stent that is 50 millimeters. However, there is the problem to accommodate a drug-eluting stent that has a size here, okay, that fits with what we will measure here. And we expect a really huge left main according to CT scan. And if we will treat everything, we will have to deal with eventual problems in these branches independently, so altogether. So it makes sense to me to use a stent from here to here, looking at what happens into the septal that is huge, and then to move to the program we have for the trifurcation. This is my takeover, and the fact that we already stented this area will provide us a very nice landing zone even for a bigger stent.
Fantastic. Thank you so much. Do we have that? Yeah, Tom.
We're having lots of comments, which is brilliant, and we want to continue with the interaction. And so we've had a fantastic discussion around keeping it provisional, stepwise, simple. The anatomy. Surely this anatomy is, the syntax score is underestimated. So last night at our planning meeting, we all looked at it and went, I think that's underestimated. 4 different people did the syntax score, and unlike many of the previous reports, we actually all came out with a score of 22. 2 lesions, left main, LAD, 15 for the left main, 7 for the LAD. The interesting component, though, is we don't report calcium because it's not heavily calcified by angiographic criteria, but we have the information from CT that gives us more information. So we just have to remember syntax 1 score was angio-derived, but we agree with Slezko, Bojan, thank you for your comments.
Now, let's see about device which can be expanded up to 5.5 or 6, starting from smaller diameter.
So just history in a glance, because this is the Ultimaster history that proved to be a great stent in terms of vascular repair and fantastic coverage within 1 month, 85% of the struts. Then we had a century study when the stent proved long-term safety and efficacy in more complex population and to be non-inferior to that time the best-in-class stent we had, and a huge Ultimaster registry of more than 37,000 patients that showed a very low rate of target lesion failure, not only early but also in a long-term observation up to 5 years. And perhaps you remember 4 years ago we published the Master DAPT study showing that this stent in a high bleeding risk population is very safe even if we reduce the dual antiplatelet therapy to the one only for the 1 month. So what's next? So the member of this Ultimaster family is a Nagomi stent, and a study, a very extensive study of the stent was planned. Why? Because 30% of our patients currently is a complex population, but complexity does not mean only anatomy of coronaries, but is also complexity goes far beyond anatomy. For example, almost a half of our patients currently we treat in our cath labs is a high bleeding risk population. Yeah? So this is something that adds to complexity and the risk, and we know that this stent is very, very safe in this population. So the Nagomi complex study was designed to evaluate the safety and performance of this stent and offer, of course, a real-world insight into complex patients' populations. Again, complexity is not only the anatomy of coronaries. So I'm happy to announce that the study enrollment has finished a few weeks ago. This is the population of patients, so long lesion, long stents, multi-vessel disease, left main disease, 2-stent bifurcation, severe calcifications, CTO, instant restenosis. Just to give you some idea what kind of patients we enrolled, these are just 3 patients from my center. You see a very calcified ostial LAD lesion, a very long lesion in the LAD with CTO at the distal part of the vessel, and a very complex on the right-hand side anatomy of left main. Stenosis also very calcified. So this kind of patients were treated and enrolled in the study in my center. So why Nagomi? Because this is exceptional stent. So the first thing, this stent comes in a very impressive variety of lengths and diameters. So as Francesco mentioned, you have up to 50 millimeters of the length. But what is especially important for left main treatment and for any bifurcation is the huge, is a great post-dilatation limit. So you can imagine that you can post-dilate 3.5 stent up to 625 millimeters. Yeah, so more than 6 millimeters without losing integrity, not only of the struts, but also a polymer and a drug. So this is how the stent may work, and it will be great stent for this anatomy. So these are the distribution of complexity criteria that help us to enroll the patient patients into the study. Majority of them were lung lesions, multi-vessel PCI, and more than 3 stents implanted. Of course, one-fifth of patients with CTO, calcified lesions, bifurcations. On the right-hand side, you see the same distribution, but with high bleeding and non-high bleeding risk population. And as I mentioned, about 50% here, exactly 45% of patients who were classified as high bleeding risk. They were older, 75 versus 65 for non-high bleeding risk patients. There were more female gender in this high bleeding risk population, of course, because of the age, more diabetes, more hypertension, higher creatinine level, more AFib, more prior MI, prior PCI, etc., COPD and peripheral artery disease. So really very, very complex population, which consisted of 50% of the total population. Also here you see that the radial access was used in 90% of patients, and by IBUS there were more calcified lesions, more tortuous lesions in this high bleeding risk populations. Roughly more than 4,000 stents were implanted, and these are data from the population from the February this year. So this is around 2,000 patients, so more than 2 stents were implanted per one patient during the procedure. So these are the clinical outcomes, the incidence. At 30 days, you see a very low rate of target lesion failure as for general population. Stent thrombosis, 0.3%, very low rate after 1 month. And now look, this is the high bleeding risk population, much higher incidence of those of MACE. And as compared to non-high bleeding risk population, for example, there were no bleeding, 0 bleedings in this non-bleeding risk population, so no bleedings at all. And stent thrombosis was only 0.1%. Imagine 0.1% in a very complex population of patients. So just to summary, the Ultimaster Nagomi is a stent optimized for high-risk PCI profiles. 50%, almost 50% of patients were classified as high bleeding risk in this population, and the stent demonstrated superb short-term clinical outcomes with a very low TLF of 1.4 and stent thrombosis rate of 0.3%. Thank you very much.
Thank you. So we know the anatomy, we know the characteristics of the stent, and these are the key objectives that we received from the team. So PCI of the distal left main trifurcation plus mid-LAD. Procedural strategy will be image-guided by OCT, Nitrosystem Gentuity, step-by-step provisional, as we all agree here on the podium, and to understand the mechanical properties of the Ultimaster Nagomi stent. 7 French radial access, wiring 3 vessels, lesion preparation in the left main, adapted to intracoronary imaging evaluation, distal left main to LAD stenting, septal branch protection during stenting of the proximal LAD, pot and kiss for the left main, layered stepwise provisional strategy with TAP as a second stent in any of the branches if some of them becomes compromised, and the final result will be assessed and optimized, of course, by intracoronary imaging. 7 French Gleitsch slender, EBU4 guiding catheter, regular run through wires, LAD stenting with septal protection and pot, provisional left main stenting, pot, and final tracing or kissing. Ultimaster Nagomi stents, as discussed, will be used, and the OCT system is Nitrosystem Gentuity. These are the operators, and I would like to welcome them in Theater Blue. Thierry, Hakim, floor is yours.
Thank you. Hello and welcome at Massy for this live case. The team today to perform this case, I will have a great pleasure to work with my friend and associate Thierry Unterzé. We will have as nurses Corinne, Estelle, and we have as a coordinator the Dr. Akwedad, one of our associates, and as anesthesiologist, we have the Dr. Dermosh. So maybe Thierry, for the first step, you have to present us the setup of the patient.
Yeah, sure, Hakim. Hello to everyone. I'm very delighted to be part of this session. So you know the case, you know the strategy, and this is a setup we have done so far. So this is a 7 French royal access with a glide slender, which allows to use 7 French catheters through a 6 French hole. So it's very interesting. This is extra backup sweep on 75. The extra backup 4 was a little bit too long. So we decided to switch for a 375. And we have 3 wires in place. I just want to show you first that we use multipurpose to cross the acceleratory to minimize the friction. And now we have 3 wires. The main wire will be the BMW as a conventional wire. It's also interesting because it has a different color, so we can identify it very easily during the procedure. And for the side branches, we have 2 run-through wires. This one is for the, let's say, high takeoff diagonal. And this one is to wire the septal branch, because you have seen it's a very big septal and we don't want to lose it. So this is the first angiogram. So as expected, we have a huge and very severe mid-LID lesion and severe distal left main lesion. And we already perform the intra-imaging coronary, and Hakim will tell you about that because it's very interesting, you will see.
And thank you for the very interesting introduction and presenting the case and also the technique. So what can we add information with using intracoronary imaging? First of all, it is very important to precise the strategy. First of all, we have to determine where is the proximal landing zone. The proximal landing zone, the first element which is very interesting is the fact that the ostium of the left main is not diseased. So Thierry, it will not be necessary to stent the ostium of the left main, which is more simple, because when we stent the ostium, we have the possibility to have a compression, longitudinal compression of the stent. So without stenting, it is easier. We can clearly see here
Hakim,
the
just wonder
stenosis.
Hakim, sorry to interrupt. I just wonder if we could have the imaging on large screen, just so we can get
switch angio and OCT, so we see. Thank you.
Great.
You're welcome.
Sorry, we lose
can
your face.
clearly see. That's not the image is more important. So you can clearly see a concentric lesion of the left main, and to define the strategy regarding the plaque modification of the distal left main, we can clearly see here that we don't have any criteria to use any device to modify the plaque, because the calcification is not circumferential. We have here 90 degrees of calcification, as you can see here, and the calcification is not really deep inside the wall. Here we have another interesting image, which is the bifurcation with the ostium of the circumflex, and we can clearly see that the circumflex is not diseased at the ostium. It is important also to define the strategy. Then we go to we can move to the LAD, and we can clearly see that we have calcifications here. We have also at the tightest part of the LAD here, we have calcifications and fibrotic plaque. And what is very interesting here, we have what we call a lotus root. That seems that it was a small occlusion of the LAD, Thierry. It is a surprise for us because we didn't get that with the CT scan, with the angio also. So it is one information given by the OCT. As you can see also, a remark, this device, this catheter, gently catheter, is very interesting because the diameter of the catheter is 1.8 French. So it crosses very well tight lesions, so we can perform intracoronary imaging before achieving the angioplasty, and we are able to get more information if we don't use previous dilatation inside. That's very funny. We can clearly see here the lotus root. The other element which is very important is to define and to determine the landing zone of the distal part of the treated area. So here we have, as a diameter, we can define the landing zone here. So we have 2.5 tree. We will focus on that. 2.5 as the diameter of the landing zone. And for the landing zone at the proximal part, we have as 4.6 as the diameter of the left main. Okay?
Yes.
So we will see that. And for the length, let me show you an important also parameter for the proximal landing zone. The length of the left main is 15. So we have possible, we can put a balloon of 12 millimeter to do the pot. It is very important to be really precise with the pot area.
Thank you very much,
Okay,
Hakim.
Thierry?
Really excellent explanation what we see. Yoshi, would you add something on this one? Based on this one, would you recommend to use two separate stents or go for one long stent?
I think when you look at this proximal LAD, it's diffusely diseased, and I thought maybe initially, based on the CT, you could put two stents, but if you put the two stent, I'm afraid that there was some kind of the remaining plaque in this proximal LAD, so maybe I would go for the long stent to cover all the region in the proximal LAD.
Yeah, Tom?
But yeah, I mean, Hakim, that was the most wonderful demonstration of pre-PCI imaging. And I think in terms of the educational message, the essential element here is what do you want out of the imaging? And we have established so many things from this. So as Yoshi says, we've looked at that segment between the two lesions and we're going to be covering them. It answers Giorgio's question asked here. Another element is understanding that caliber disparity between the left main and the LAD. And so we have 6 in the left main and we have 2.5 as a distal landing zone. So we've heard from Maishet, we don't have a stent that will do that. So that automatically tells us we're going to be using a smaller vessel distal stent and then a large vessel proximal stent. And then beyond that, from what Francesco and Yoshi described in our discussion before coming live, the calcium is very much less apparent by the imaging. And that demonstrates the flaw of the CT being unable to tell us whether it's luminal or deep. And we see that it's probably deep behind some lipid, and so is less of an issue procedurally at this present time. So bringing together all 3 of those pieces of information, the CT to the angio to the OCT, has given us the most incredible amount of information.
So actually, we really tailor strategy based on the OCT. A low profile allowed us to avoid predilatation and dissection. Now we know we'll go for predilatation distally, and Thierry is working on mid-LAD, prox-LAD stent.
Yeah, I already done 3 predilatation with a 2.5 non-compliant balloon. And you see the result after the predilatation is quite good. And we can now move to the stent. And according to the imaging, Hakim,
Absolutely.
we decided to implant
To implant a stent which is
3.0.
3.0 and a long stent, 33 millimeter stent. Yeah.
So just to make clear, if we correlate OCT and this angiography, your distal landing zone is beyond this curve. There is additional lesion, so you will cover that lesion as well. This is additional information that we got from imaging. And to protect the side branch, in this case, a really big septal branch, honestly, I personally really respect this decision to maintain patency. It's huge branch. There are other septal branches, but I believe putting additional wire that we will use later on to put it in another branch in the left main is really creating safety for this procedural segment. Maciej, you want to?
Yeah, maybe the stent they're gonna use is also a very good option for the septal branch because after post dilatation you can obtain a really big cell. Yeah, so the risk of the coverage of the cell. One thing is thin strut stent, and another thing is that the cell will go really. Yes, so only 2 links. So that the risk is not zero, of course, but it's much lower than with the other stents.
So Goran, Maciej, it's actually generating some discussion. Why do you wire the septal? Does anyone really care? How far are you going to go to saving the septal? It's an interesting discussion.
I would protect the septal with wire. It does not mean that I will fight for the nice results in the septal. I just want to have it open and TIMI free flow.
But I guess I wouldn't have wired it, but I'd have regretted it when it closes and would have to save it. But I guess then the next step from a technical perspective is, do you then pot that side branch as you would other side branches? Or are we just respecting it by wire to prevent it from closing? I guess
since we are losing the imaging, then we'll know if we need pot or not. Without imaging, I would do the pot because every branch takes off from the main vessel. The vessel narrows, so that's normal. But since we will image after procedure, then we'll know. Yeah?
And we will overlap proximally, so post-dilatation will be performed in that segment anyway. So now we use stent boost.
Yes, we love using this kind of device because it gives a lot of information regarding the opening of the stent, and so then Thierry, you will.
What was the inflation pressure?
12 atmosphere for the inflation pressure, and with the stent boost we can see that the stent is well open. We'll confirm that by intracoronary imaging at the end of the procedure. Thierry, do you want to perform a pot on the proximal part just before the septal?
Yeah, because it's a huge septal branch. So according to the fractal law, the proximal part just before the septal is probably bigger than the 3.0, and we confirm that on the NIPRO images. So I will perform a pot on the proximal part of the stent just before the carena of the septal branch. And if the septal is patent after the pot,
so it's 3.0 by 6 or by 8?
It's 3.5 by 8.
3.5 by 8.
On va se mettre en 3.5 by 8.
Daniel, any comments? Would you follow the same steps?
Well, I like the strategy they have chosen to put stents in, so you can care of this bifurcation, and you have not jeopardized 2 bifurcation or even a trifurcation, so you have your time to solve this. Yes, I would do a post-dilatation with 3.5 because I think it's an LAD. And it's at least 3.5 at this point. You should do post-dilatation in the pot.
There is a nice pot puff sign that you can inject just few cc's on contrast while you are performing pot. And if you obstruct the flow completely, it means that sizing is adequate. But you can even see now.
Très bien, pareil.
This Thierry is looking at the proximal part of the stent to perform the pot.
To
at
pull
the
back
proximal part of the
to
stent.
cover the proximal edge.
Yeah, yeah.
So usually with when we do some stent boost, we just focus on the balloon, but also we have to keep in mind that there is a tight distal lesion, and if we move the balloon without seeing clearly the guiding catheter, sometimes we can create some deep intubation into the lesion. That's why I decided to do it on that side.
Yeah, as long as we have jailed wires after stent, we need to really keep on the same plane tips of the wires as well as guiding catheter, so both could potentially create complications.
It seems to be good because
geographically
we have the septal. The septal is open with the T3 flow. Are you okay with that, Thierry?
Yes, there is some slow flow on the septal branch. So maybe we could continue the treatment of the left main and go back to the septal if there is some occlusion, maybe.
What is your opinion, Goran?
I would not open that branch now. There is some edema. 3.5 is very large. We have still good flow. I would focus, as you said, on the left main, and then later, if necessary. We don't expect that vessel to be occluded.
Of course, unless the patient starts complaining.
And these septals are often very symptomatic, right?
Yeah.
So the symptoms may well guide that. Hakeem, just before we start focusing on the left main, there is just one question which I think is relevant. Having taken that care to look at the imaging and the distal landing you suggested maybe lumenly was 2.5, you've gone for a 3.0 stent. So would it have been a 2.75 or a 3.0? What was your rationale for choosing a slightly larger stent to the distal vessel landing?
Because I was very distal for the landing zone of 2.5, because there's an intermediate lesion of the distal part of the LAD, but the landing zone of this area, stented area, was more than 3. It was maybe 2.9 as the landing zone of the stented area.
And so just to be clear, you're rounding up from the lumen to the
2.5 is the
And this is actually the only stent platform that you can implant 2.0 and upsize up to 3.5. So this really allows good expansion capacity. Now we see 3 wires. What is the next step?
So we're going to do the predilatation of the left main before stenting the left main to the proximal LAD.
NC balloon.
So we are using now NC balloon. 3.5.
Actually, it's a 4.0.
4.0, sorry.
4.08 length. Because the distal left main was about 5 millimeters, so we start with 4.0 as a preparation of the lesion, and let's see after if we can stent it or perform another predilatation with a bigger balloon.
So you will predilate only inside the left main?
Yeah.
Well,
I mean, a little bit proximal to the LAD also, Goran. Okay.
Test ça.
Attention à ton guide. Ouais. Okay, maybe we have to move a little bit the wire on the diagonal branch. That's it. We are at the right place.
20.
As we saw, we don't need any device to modify the plaque because the balloon is well open, as you can see here on the distal part of the left main.
Yeah, thank you for that comment, Hakeem. You know, since imaging got class 1 recommendation, there is really huge request, use imaging, but I like very much comments of Tom on various meetings that we need to react based on imaging. Otherwise, we really don't use the full potential. And in October, we see that stent deformation is actually a huge problem that is not easy to detect on imaging during the procedure. Tom?
Well, yeah, I mean, I think you're rationalizing the use of imaging quite sensibly, and having used it in the pre-procedural phase, as we said, there were some key features you wanted to recognize. You've made the measurements. We see obviously dissection there from that large balloon in the left main, but you're planning to proceed to stenting now. But as Goran says, maybe the next essential point for imaging will be having undertaken a pot with a balloon appropriately sized by the measurements we've had by the pre-procedural OCT, but having undertaken that pot, maybe to then recross into the circumflex and or the intermediate, and then do the OCT, because then you get both the assessment of the stent and the optimization of the proximal left main segment. But you also will assess whether there has been abluminal wiring, and you have a greater understanding of whether you're going to be at risk of longitudinal stent deformation. So I think that, for me, would be the next essential point, that you bring the imaging catheter out again.
So stent, pot, rewire, and then repeat imaging, because that's the key point to get additional information for the rest of the procedure. What stent you are going to implant now?
So we are going to implant, of course, a Nagomi. The size of the Nagomi is 3.5, and the length is 38 millimeter long.
Okay.
So as you know, we will be able to get a very large diameter on the proximal part, at the distal part of the left main, because with this stent, the capacity of expansion is very, very interesting.
So patient does not feel pain now. Patient is stable.
No,
dynamic.
it's very stable. No pain. The hemodynamic is very.
And the
very
septal
good,
branch looks slightly better now. Maybe important is not to cover with the second stent the septal. Yeah,
of course.
With double layer of metal. Yes.
And Thierry, Hakim, you've got lots of people watching your wires, but you've already indicated how critical it is with 3 wires on the table to know where they are and to control them. So there are people just watching out for your distal wire placements, but I think you're being as vigilant as you can be in that setting.
Tom, one of the main learnings that I had in all these years from Massey is that position of the wires that you see on the screen should actually be replicated on the table. So when you pull, you know which wire you are taking.
Yeah, and we have different colors because, as explained Thierry before, we have the 2 run-through wire, one on the circumflex, one on the diagonal, and the wire on the LAD is another color. Because the run-through wire are blue, and the other wire is green, which is a BMW wire.
I wonder whether Francesco can then, when they come.
Thierry, you need a little bit more. It's going on. You have to take your time in this case.
Yeah, with 3 wires, you have to be patient and wait.
Yeah, of course.
On va faire juste du stent boost. So now with this cranial view, we're gonna focus on the overlap part with a stent boost. We don't need contrast, so it's too far, clearly. And we don't want to cover the septal branch.
So maybe we have to make an angio, to do an angio.
I pull back a little bit more first. Alors on se fait.
Yeah, that seems better. Huh?
No, it's quite the same. Test.
Vas-y, fais un angio.
Oui.
Ouais, une angio.
Allez-y.
OK.
Le liode.
On va l'implanter.
1 millimeter works.
On met un angio. Fais une angio, Thierry.
Yeah, maybe Thierry, you can pull back a couple millimeters.
Yeah.
There is dissection. We don't like to be at the edge, so.
Sure.
Now the position is correct because there is
Yeah.
a small gap
The
between the
position is
marker and the
correct,
stent.
yeah.
Yeah, so you should
bon.
not pinch the
Okay.
Petit test d'abord.
side branch.
Yes, we are at the good place because we don't occlude the septal branch. We are covering the dissection and the distal left main, and we don't cover the ostium of the left main. Maybe we will at the after that we will do the pot.
Yeah. It seems that
Okay.
delivery balloon is fully open, symmetrical.
Yeah, 14 atmospheres. Okay, off.
The main thing actually during this phase is to watch the hemodynamics, of course the patient
Yeah.
status, but thank you for presenting us the screen with the hemodynamics so we can really follow, like being behind your shoulder.
Also, then now, Thierry, essentially you're backing the
You
guide
have
catheter
also-
out, right?
Yeah.
So this point of distorting the stent, which is going to be significantly underexpanded in the proximal left main, is critically important, right?
Yeah.
One thing which
Absolutely
is also very important, you have to take your time to deflate the balloon, because especially with long balloons, and because sometimes you create a compression of the stent, even when the stent is not at the ostium.
I see that Francesco carefully monitors the steps. Francesco, distal optimization before or after proximal optimization, what would you recommend? Does it make difference?
Donc on va prendre le 408 maintenant. On va prendre
Can we have the microphone of Francesco?
That's it.
Guided.
Estelle.
As soon as you have the stent that is floating and deeply malapposed into the left main, you have risk of distortion. So it makes sense if you have to dilate both the proximal stent into the left main and the distal to expand well, to firstly expand in the left main and then come back to optimize thereafter, because advancing the balloon even you may have distortion.
Yeah, the dissection segment is covered. Now we need, of course, to post-dilate and fully oppose stent.
So if you want, I can comment a little bit now. So the result with the angiography seems to be nice, but we have a lot to do now, because first we want to perform a pot just before the diagonal, the origin of the diagonal. So probably a 4.0 would be suitable. And I removed a little bit the jail wire on the diagonal because I don't want to have an entrapment. So now I'm completely free, and I'm going to perform a pot just at the ostium of the diagonal, and then do another pot dedicated to the left main with a bigger balloon.
You mean the proximal part of the LED, the pot, to open the strut just near the diagonal branch. So that's why we use the 4.0 balloon only to open and perform the pot of the proximal part of the LED. The real pot of the left main will be done with the biggest balloon, of course.
So you are using now the same balloon that you use for pre-dilatation of the left main.
Yeah, but maybe we will change, because sometimes it is better to change balloons.
4-2-8 and C9.
To be a crossability, to have a crossability.
So many questions from our attendees in the room.
So there was this consideration around dot and pot, but it also particularly, Francesco, then where to place the pot balloon. And I guess one consideration would be proximal to distal, distal to proximal in terms of
direction
that placement.
Proximal,
Yeah. There are some comments about the lengthening of the stent, but kind of coming back to that pre-procedural OCT and understanding how long that segment of disease might have needed to have been covered. But it's looking fantastic in terms of the result you're achieving.
Yeah. Yoshi, you agree with the current procedural steps?
Yes, yeah.
Disease that we did not appreciate angiographically was now fully covered with adequately sized stent in the proximal LAD.
Yes, I completely agree because the proximal part where LD was diffusely disease and there was a diffuse plaque there. So I think to cover that part is important.
Exactly. What we learned from the October is not to finish with stent in the middle of intermediate lesion, especially if there is lipophilic content in it.
Yeah. It seems to be the good place, Thierry, to perform the pot of the proximal area of the LAD. As you can see here, not so bad. Okay, go.
So what is the size of the pot balloon now?
4-0.
4-0.
It's a 4.0 and 8 millimeter length. So you understood that the distal part of the left main of the LAD, will be respected because we have an intermediate lesion also at the distal part of the LAD. So now, Thierry, I've done the part of this proximal LAD, and we will see if we need to do a side branch opening or not regarding the diagonal branch. So the ACT is good, more than 300.
So Hakeem, Thierry, there's just one comment here around selecting the pot to the diagonal first over the pot to the circumflex, and why you've made that choice rather than working proximal to distal. I guess they make a valid comment that there just is a concern around withdrawal of a pre-used balloon leading to elongation. So I guess that's just something to be procedurally aware of, correct?
Yeah. But we used a new balloon, but we will use for the left main another balloon with a diameter bigger, of course, than this one, because this one is only 4 millimeter of diameter. So we will take another one.
Yeah. So maybe one of the advantages.
It is a sorry.
One of the advantages of starting with the proximal part is that the sooner you oppose the struts of the left main, the lower the risk of deformation. Yeah? So that's the in theory, but many of us start with the distal, and if you keep it in mind and check it, have imaging, and you're sure that you did not deform the stent, then this is okay.
I mean, we're seeing
but Thierry is doing a new concept because he's performing now a pre-pot with a small balloon. So we will open all the area of the left main before using the real balloon for the pot, which be Thierry said 5.0.
It's 5.08 according to the
diameter of on the intracoronary image.
On peut prendre le 5.8.
with your
By
fluoroscopic imaging.
the lumen was.
Hakeem, with your fluoroscopic imaging, you're seeing beautifully the interaction between wire and stent and the balloon. So we saw clearly that undersizing of the proximal stent segment that will be overcome with this larger vessel pot, right?
Yes, absolutely.
Francesco, any comments regarding this strategy 4-0 for ostial part of the LAD up to diagonal, and then?
Well, once we recognize that it is basically a trifurcation that consists anatomically of a double bifurcation, we realize, and with the branches that are important, we anticipated that there are 2 steps in terms of size increase. So this is very smart way regarding the possibility to perform a POT in the left main before that into the LAD we discussed. I want to recap. Usually it is better to perform the proximal part before, but when you are jailing a wire in a side branch with a long segment, you have also increased risk of jailing and entrapment of the wire. So every single decision we do, there are benefits and drawbacks. So the colleagues decided to go on with that, being very careful in managing the interaction between the guiding catheter and the stent that was malapposed.
Goran?
Yes, Hakim.
It is now a very important step, as you know, of the procedure of bifurcation PCI. So Thierry will explain how he will do the pot for this case. Thierry?
Yeah, so we selected a 5.08 length balloon, and we go to perform the pot distally to proximally. And now we are focusing on the carena. So this is stent boost, but we definitely have to inject some contrast to see exactly where is it. So injection.
Thierry, what are the optimal angiographic projections? In this apicodal seems good. Would you go also to spider to double check when you open more?
Yeah, you're absolutely right. Usually it's left caudal view, and sometimes we have to have a double check with the spider view. So we will do that because it's a really key moment for the bifurcation treatment, and especially for left main.
Very good point.
So we have to focus, because you know the distal pot is very important to recross the wire. So it's now a key moment. Yeah, injection. I think I can go a little bit distally if you agree.
Yeah.
At least 2 millimeters.
1 millimeter.
Yeah.
But the important consideration there is often the wire into the side branch is used as a landmark, and what we see beautifully here is the separation of that wire very proximal in the bifurcation.
Exactly. Because of the jailing the wire, actually you push wire laterally. And you have separation much earlier than anatomically origin of the side branch.
Yeah, that's it.
Yes, clearly.
On peut gonfler.
So the pressure is, on va faire 16.
Stop.
And we will do a puff technique at the proximal part of the pot, Thierry. So now he will perform the pot at the proximal part of the stent.
So we have to take our time, because the deflation time for the balloon is very important. If we do it too fast, we can create proximal compression of the stent. So we have to take time, and sometimes, to be sure, you can push a little bit the balloon to confirm it's completely free. And with my left hand, I go back. I just put my extra backup in the aorta.
We see that you disengage the catheter while you are pulling back.
Exactly. On va se prendre un stent boost maintenant.
And boost again. We use a lot of stent boosts. It is very useful for putting the balloon at the right place for the pot.
And selection of 8 millimeter length instead of 12 or 15 in this case with longer.
To be sure that we do not have any geographical miss by performing an angioplasty with a balloon on an area without any stent inside. So with a smaller balloon, it is more comfortable to check.
Yeah. Actually, this is one of the most critical inflations at the proximal edge of the stent. You have to be sure that you open, but you also don't want to damage proximal tissue. So
that's the point. So it was 20 atmospheres for the last inflation on the proximal pot. On aurait pu faire un puff.
Yeah, Let's review the result, and then we have to rewire
Right.
and do OCT, Yoshi.
I think that's the most.
In your study, which I really learned a lot from your optimum study, that even after several attempts, you are not really always able to go through the cell that you wish. Can you comment on that
Yes,
also?
yeah, that's true. I think if you do the OCT just after rewiring, half of the case you take the distal, but half of the case you take the proximal cells. And to correct the proximal to the distal, sometimes it takes multiple pullback and multiple attempt.
Following all this analysis in that study, what would you recommend? Keep that wire in the position that you attain and take a new wire, or remove that one and try to cross more distally?
I would recommend to keep the wire in and
Keep
take
it
the new
inside
one.
and take a new one.
Yes. So that you can
Goran,
use
we
it.
have a couple of questions again regarding the pot, which don't know whether, maybe to you, Goran. So, optimal duration of a pot balloon inflation? Is that something that we have any understanding?
Actually, it's much more about diameter than duration of inflation. You don't really need high pressure or high duration. You need diameter, which you can achieve by adequately selecting the size. And inside the left main, of course, by monitoring hemodynamics, it's the variable that you can adapt.
And then might check the design of the balloon. Do the shoulders matter? So there was another question around that.
And another issue for the left main, when you can very often you cannot prolong the inflation, but if you do 2 or 3 times, every inflation will go slightly higher. The diameter will go, because balloon is more like elastoplastic, not elastic. So if you inflate 3 times, the expansion will be better.
But also it's important that...
So now...
sorry, Akim, please.
No. So Thierry is going to cross the strut on the left main. And as you saw, he went before on the proximal LAD and going back to fall in the ostium of the circumflex.
Yeah.
That's the way we do that. I'm not sure that
maybe
is
position
the distal.
Maybe it may be the proximal cell you took.
Yeah.
But angiography is
completely agree
misleading,
with that.
So
Yes.
it's you cannot tell, upon angiography if you cross the proximal distal strut.
But there is an interesting geometry to this left main, right? That there's a slight curvature to it. And so Yoshi, a Japanese experience would be dual lumen catheter very commonly being used at this point in the procedure. So there's a role for that here if we're not successful. Does that make any difference to your success in getting the right cell?
Yeah, I think it's a little bit depends on the experience of the operators, how much you are familiar with that technique. But certainly this dual lumen catheter is helpful when you cannot really cross the wire to the side branch, in this case circumflex.
No, as you can see here, we have the same positioning as the jail wire. So it is not the good way to get the distal strut. Usually we have a small distance between the jail wire, which is on the proximal part, and the wire recrossing the strut. So 1 millimeter should be a very good distance between the both wires. That's the way we control the fact that we get the distal strut. Angiographically, I mean. But of course, with the
tip of that wire seems to be damaged, so I agree with Thierry to take a new wire.
Yeah. Absolutely.
So maybe one more comment about dual lumen catheter. What is the advantage of dual lumen catheter in this maneuver is preventing abdominal wiring. So definitely for this. But I'm not sure if the dual lumen catheter will help to getting into the distal strut.
I mean, on occasion, I think it does change the orientation of the wire within the vessel. So if you're having real difficulty, then a consideration would be to use that. I think what's often overlooked, though, is the importance of an appropriate curve to the wire. And I don't think that's necessarily always well taught. So it's really interesting to see Thierry here take time to reshape and to try and change the nature of the wire behavior.
I think this is a very important remark because it's not about dual lumen. I think it's more than 90 degree, and when you want to wire more than 90 degree, the shape should be more than 90 degree. If not, you cannot wire in there. And I think this is a very important
and
comment.
the reach of the wire needs
Yeah.
to be sufficient.
And
So
the
maybe a
curve-
5 or
diameter
6
is big.
millimeter
Yes,
reach.
exactly.
Yeah.
And the diameter of the vessel is high here, so the curve should be longer than usual. Huh?
Then the reference, yeah.
Okay, now it looks okay.
Yeah, looks better.
Yeah, it
But we
looks
will
better,
do
but
we will do
are in a
OCT
small
anyway.
branch. Maybe for the time, we will do the, if you don't mind, we will perform the kissing.
Absolutely,
And,
absolutely
and
agree.
then,
To optimize the result and then
we'll,
do
yeah.
at the end.
And we will do the final OCT at the end of the procedure, if you are okay with that.
Absolutely.
Let's come back.
We will let you ask the question as soon as we finish with the transmission. Give us just 3-4 minutes to finish this interesting part. Then floor is yours,
Okay.
of course.
On peut prendre les ballons.
So, les ballons de kissing.
No, go.
So we're going to do now the kissing. Maybe, tu as le petit robinet?
So what are the sizes and types of the balloon for kissing that you will do now?
Thierry, what do you want as a...
4.012 for the LID and 3.012 for the circ. We definitely need to take small balloon to avoid to damage the previous putt and to go just on the polygon of confluence.
Okay, that's an important thing, that we will not go far in the polygon of confluence. We will go more distal in the branches. And we will use this tool, which is very interesting to perform a kissing balloon. It is a tap with a three-way tap with 2 male that allows us to perform the sequential inflation of the balloon. You can see
4.12.
Yes, we can
that.
see it.
C'est quoi ça? C'est quoi?
So just for our attendees here in the room, since pot was performed at the level of the ostium of the first diagonal, now we are not going to do tracing. There is no need. We actually go more proximal, and with inflation of 2 balloons, one towards the LAD, the other towards the circ, our goal is to oppose stent better in the polygon of confluence, but also position carina in the center.
As you can see here, the balloon crosses the ostium of the circumflex and the struts very easily, because the pot, I think that the pot was well done by Thierry. So now we're going to put the second balloon on the LAD, which is a 3.5, 4.0?
4.0.
Okay.
Maciej, any advice regarding the sequence at this stage?
Yeah, I would start with inflating the balloon in the side branch, not high pressure, and definitely in the side branch we need an NC balloon just to reduce the risk of side branch dissection. Yeah. Then I would go higher pressure in the main vessel, and then deflate and simultaneously like 8 atmospheres just to go to nominal, because the main role of kissing is to bring back the carina into the central position and then to improve the apposition of the stent in the polygon of confluence area. So,
Okay.
so this is what I usually do. Yeah.
Okay, c'est bien. Okay, so we have done as you said, Matt, the inflation on the side branch,
the circ, yes.
and now on the circ, and now we are going to perform the inflation in both. So I turn my tap like this and deflate, and now we're going to perform at 12 atmosphere, à 12, the kissing with the two balloons,
Francesco
as you
also
can see
has
here.
similar technique that he's advising. When he did the live case in the main arena, it was demonstrated really clearly.
30 secondes, faut faire.
Ah,
OK.
And of course, the balloons should be sized according to the diameters of the distal
Absolutely.
branches. Yeah. So if it's for
So we're
0
gonna
in the LED,
remove
then
both.
for 0 it's 3/0 straight
Yeah.
and 3/0.
the circumflex. The final pot.
Are you going to perform final pot?
Yeah. We are going to perform, Goran, the final pot.
Okay.
And then we will perform the
OCT.
angio,
Okay.
the OCT.
But final
intracoronary
pot is
imaging,
actually
to show
just
that
for the proximal part of the stent. You don't
Yeah, of
come
course.
close to carina.
It is.
That part is already fully
Different.
opposed, and it's anyway elliptical shape. It's not circular.
Yeah. So if you're gonna take a new balloon, you can take a 12,
Yeah, new balloon.
not
new balloon.
necessarily 8.
Yeah,
Yeah.
with new balloon,
Et-
not to damage the edge of the
Avoir
proximal stent.
5,
Non, mais
ou un 5 si on en a un autre, un 5.
So many
I'm
comments?
trying to respond to as many as I can by text for the purpose of not wanting to interrupt the great discussion. So there have just been some ongoing comments around the technique of POT and issues around which of the side branches you prioritize. We've seen, obviously, the circumflex in a very pragmatic approach. Obviously, we will await then, I guess, both the angiographic and the OCT results to then see if there's anything more that needs to be done.
So we decided to be sure that we will have time to perform the intracoronary imaging, and we will see if we need to finish with the final pot. It is more important, I think, to achieve the final intracoronary imaging to be sure that the result
To examine the result from inside.
Yeah. And we
I
will
think we
decide,
have great experts here on the panel to help you do that. So very good idea to do imaging.
I've had some experience with Gentuity, and so just for those not familiar with the technology, so as Hakim mentioned at the beginning, this is a very low-profile catheter, so 1.8 French. It has a very fast pullback. So what we'll see is that there's the ability to pull back up to a maximal length of 100 millimeters in
So
just
10
one
centimeters
second.
In 1 second.
Yeah.
Which means that the contrast use is smaller, is lower. Right?
The HF relates to high frequency, and so the properties which Yoshi will be much better at speaking about of the light source mean that you potentially get a deeper penetration of the vessel wall. Is that right, Yoshi?
Yes, and also the frame per second is very high, 250 frame per second, so that you can go for the very high speed of the pullback, but you can still have a good sampling rate of the longitudinal resolution.
I mean, Hakim, it'll be really interesting to see the nature of this bifurcation following the KISS. There's just one comment from Ahmed in terms of, is it necessary to KISS all left main bifurcations? So obviously you had Timmy 3 flow, and I know that it's the Massey way, and I'm a kisser too, so I would have kissed. But is there any comment about, are there any bifurcations you wouldn't kiss, I guess is the question.
passe pas.
Yeah. For the left main, we always do kissing in our practice. But for other bifurcation cases, when you have a small side branch, usually we do a pot, side pot, or only pot if the branch is really small. But for the left main, which is a very special bifurcation, we need to do the kissing technique to be sure that the carena is at the right place, and to be sure that we can go to the circumflex if needed, if we have a stenosis, and it is very important to have the ostium open and do not have any struts regarding the ostium of the circumflex if it is needed.
So an extension to that question, Hakeem, comes from another colleague, which would be having then kind of instrumented the side branch, would you consider a DEB for the side branch?
Which one? Sorry.
So having now ballooned the circumflex, does that commit you then to having to use a drug-coated balloon or a DEB, or you're happy just to have opened the struts?
Yeah, it's a good question, very good question. But in this non-diseased circumflex, we saw that in the intracoronary imaging, it was really clear that the ostium of the circ was not diseased. So, in my opinion, it's not necessary to put a DB inside the circumflex. But sometimes, when you have a side branch diseased at the ostium, for small branches, we use a DB to reduce the risk of restenosis.
Thierry,
this catheter is very small, so sometimes it's very easy to cross when you have de novo lesions, but sometimes with the struts, it seems to be more complex with the stent, so we will use another catheter to be sure that the result is correct. Thierry wants to perform another inflation on the proximal LAD.
Yeah, because as you said, the NIPRO is very low profile and very fragile as well. I'm not able to cross the proximal LAD. So I decided to use a 6 French extension because that device can go through inside. But even with that device, I was not able to cross the proximal ID. So if we want to assess the final result on imaging, we necessarily have to optimize a little bit the proximal ID with 4O balloon.
It crosses very easily through the...
No, I have some resistance as well. On va faire une graphie.
But actually, from a procedural point of view, I think this is essential because you're coming to the end of a procedure and potentially you have that first feeling of elation that you've done a good job and everything's great. And then you have the frustration of not being able to deliver a device. And then you're at risk of getting into a battle that can only end in one way. So staying cool, and as you're doing, then sequentially post-dilating, delivering again, is exactly the right thing to do, isn't it?
Thank you, Tom, for this remark. And Thierry is doing the angioplasty, completing the angioplasty of the LAD, and we will try to perform now the intracoronary imaging, as very safely, of course, because it's the main goal. But we saw with this case that we had a lot of information given by the CT scan and the angio, but we also had a lot of information given by the intracoronary imaging before performing the PCI. So it is very interesting to complete the strategy with this kind of tool. So now Thierry is going to perform the control of the angioplasty.
Akin, Francesco speaking. I think that when we are using OCT, it is really uncommon that we are unable to cross the stent. But when it occurs, most of the time, if we successfully cross, at the end we find that there is some malapposition or some focal under expansion that is not captured. So since also OCT assessment implies contrast administration, I think that it makes sense to do like you did. So to post-dilate appropriately and then to go on.
This is exactly what they did.
Okay.
So you also spared the contrast.
So let's see the final OCT.
Angiographically, it seems to
Angiography
be
looks
very
really-
good.
Septal's great, isn't it?
Septal is much better as we expected.
The stent seems to be well open. At the distal part, we have a small malapposition, and maybe we have to complete at the middle part of the LAD. Okay. So, what do we have? No dissection at the ostium of the left main.
Yoshi,
Maybe
please feel free
here-
to
Comment.
Yeah,
comment.
yes,
Yeah.
No, I think this
If
study
you want
has-
to comment, Tom,
Yeah.
Yeah,
This is the
here
overlap.
we have a small.
Little-
Yes, we can make a measurement here. It is very small malapposition. Here we can clearly see that the stent is well open at this part. Here we have, check.
So there was a concern in the audience that there may be
3.9.
some bottlenecking. Mark and Hakeem, I did think I saw some under-expanded stent right at the ostium.
Yeah,
So
yeah.
there's a portion that absolutely
Yeah.
will need some further work. And there's also
Yeah.
a fairly elliptical nature to the vessel in the proximal LAD segment that is likely to require some further attention. So, I mean, I think we're running out of time, but the most beautiful element to this is the fact that angiographically we all were happy to take our gloves off. And yet now this
Yeah.
demonstrates that there's still some work to do to achieve that durable result for the patient, I think.
Absolutely.
Yoshi's nodding
So
his
we
head,
will
which gives me
complete
some reassurance.
No, I agree. I think
So it is very interesting to see that in this case, we can summarize the fact that with the intracoronary imaging, we get more information to precise the strategy, and then with a very good angiographic result, we are clearly convinced that we have to complete the angioplasty regarding the control
Thank you.
intracoronary.
Thank you very much and congratulations. I think it was very important to see the end in this very complex anatomy. I'm sorry for not letting you ask the question, but it was very important to see final evaluation and how much we can learn from imaging. Congratulations to team in Massy.
Yeah.
Congratulations to all the speakers, and thank you to Terumo for organizing this session. Have a successful rest of the meeting.
Yeah.
Marco, thank you.
Very briefly.